Let's look at fetal alcohol spectrum disorder. Fetal alcohol spectrum disorder really is one of the most common forms of developmental disability in Canada, believed to affect 1 in 100 births. And this lesson will provide a basic understanding of fetal alcohol spectrum disorder, or FASD, how it's caused, the challenges associated with preventing it, and the outcomes for the individual, family, and community. In the DSM-5, FASD is falling under an umbrella called neurobehavioral disorder associated with prenatal alcohol exposure. And this refers to children exposed to prenatally to alcohol but really don't satisfy the full criteria diagnosis of FAS. FASD, or fetal alcohol spectrum disorder, is not a mental health issue. It is a neurobehavioral, biological brain damage. But sometimes people with FASD, or many times people with FASD, children and particular, complex children, end up in psychiatrists and psychologists' offices. And so now the DSM-5 has a classification under consideration for this neurobehavioral disorder. What are we going to learn today? I hope that you have a better understanding of fetal alcohol spectrum disorder and how you as a CYC or as a professional will better be prepared to respond with appropriate interventions to improve the outcomes of individuals with FASD whom you might be looking after. This is really a module presented to you to help you have an understanding of the disability, its causes, and how it may be exhibited. So, what is FASD? FASD is caused by prenatal exposure to alcohol. That is, a pregnant woman who drinks any type of alcohol beverage in large enough quantities to inhibit fetal cell development. This leaves lifelong impairment to the body and brain of the alcohol-exposed individual. Again, I have said to you that FASD is one of the most common forms of disability in Canada. It's believed to affect 1 in 100 births. Early research in terms of the beginnings of FASD and incidence and prevalence really had profound effects on society when we learned that more than 80% of adults with FASD will not be able to successfully live independently. More than 80% of children with FASD will be raised by someone other than the birth mother. More than 50% of children who are pregnant are permanent crown wards have FASD. And estimates of incarceration vary from 15 to 60% of those incarcerated have FASD, and 94% of individuals with a disability will have at least one mental illness. Often there are multiple mental diagnoses, including ADHD, anxiety, depression, post-traumatic stress disorder, substance dependency, bipolar, and conduct disorder. So FASD is very, very complex and profound. There's no other disability where the outcomes profoundly have such poor outcomes in terms of the proportion of individuals of which who have the disorder. Outcomes include disrupted home life, school failures, victimization, mental illness, incarceration, loss of children to foster care, unemployment, and homelessness. FASD, in terms of victimization, most people with FASD have been victims of physical, sexual, and emotional abuse. At least 60% experience alcohol and school, social failure, and have children that they can't care for themselves. And those children are often prenatally exposed to alcohol, so there are generations of individuals affected by exposure to alcohol prenatally. The data tells us that FASD will need the most help. People with FASD become heavy users of extensive systems in our society, including the adoption services, child welfare, education, youth and justice, and child and youth mental health, addiction services, housing, employment, and support services. Most of these services are tasked with remediating behavior and improving outcomes. However, the capacity to screen and respond to FASD, the most common developmental disability, is only just beginning, and the DSM-5 now has a placeholder where people who are certainly able to classify FASD within that diagnostic statistics manual. So, how much alcohol can damage the unborn child? And a lot of research in the area of FASD has gone into determining these factors. Professionals and researchers across the globe have been exploring these concepts. Not every woman who drinks alcohol during her pregnancy will have a child with FASD. Some children are profoundly affected, while others have no observable impairments. The degree of damage is dependent on many factors. Research has found that older women, women with lower body mass index, women who lack adequate nutrition, women who don't metabolize alcohol well, and women who live in highly stressed environments have children who are more profoundly affected. How a woman drinks is also a factor. The fetus shares the same blood alcohol level as the woman, but it takes longer to clear it from its system, as the non-functioning liver cannot metabolize the alcohol. So binge drinking, for example, which is the consumption of 4 or more units of alcohol per sitting, has the greatest negative impact. Binge drinking is a worrisome trend because it occurs socially and specifically in younger women. Getting very drunk very quickly means that young women who are not planning to have sex and who may not be using effective birth control may become pregnant without being fully cognizant and prepared. So early pregnancy symptoms such as headache, nausea, and fatigue can mirror a hangover. And so menstrual cycles can be irregular, and weight fluctuation is common. So women, especially young women, may not be recognizing the signs of pregnancies in that particular context. And so it's these reasons that the medical community stresses the importance of pregnancy planning. So if you're drinking, avoid pregnancy, and if you are pregnant, don't drink. This is a very preventable disorder, and that's how simple that particular stance is. If you don't drink during pregnancy, you will not have a child that will be prenatally exposed to alcohol, which causes brain damage. So we know that in vitro, each fetus brings unique features that make him or her less or more susceptible to alcohol's impact. So in twin studies and early work, we see that twins who experience the same prenatal environment can present vastly different capacities and impairments. So while the impact may be more subtle or severe, abstinence is the only way to protect the fetus. Alcohol consumption by a pregnant woman can cause distress and worry. It's always advisable to check with medical practitioners to discuss the pattern of drinking and fetus exposure. And it's also important to explore and ensure that prenatal exposure to alcohol is recorded on a child's medical chart. Having this information early on will prevent the greatest opportunity to identify and respond to any delays in development should they occur. FASD is about biology. Addiction knows no race, class, or distinction. It doesn't discriminate. FASD, again, was once perceived as an aberrational issue because that's where the first research was focused and based. But when researchers began looking in other communities around the world, they found the disability everywhere. It may be more and more noticeable among the poor because they require taxpayer-funded services. However, actually studies show that the higher the education and the higher the income, the more likely a woman is to drink while she's pregnant. The stigma associated with alcohol abuse keeps many women from seeking help, and it also makes some doctors hesitant to ask the question. It's easy to ask a woman of a different race or socioeconomic background than someone who might be a peer. In some cases, it's profoundly difficult for women to share their history and their prior use of alcohol use. And research into incident rates have found that 4% of women drank heavily in their second and third trimester, and 20% of infants in the neonatal intensive care unit were prenatally exposed to alcohol. Of these women, only 1% share their history of alcohol abuse or alcohol use, and with their healthcare practitioners, and declaring embarrassment or shame associated with alcohol use in pregnancy as the reason why they won't share. Much needs to be done to provide information to all women and to better prepare women for pregnancy in order to reduce the incidence of FASD. A fuller menu of treatment options are needed. More addiction treatment programs recognize the specific vulnerability and opportunity a pregnancy can play in recovery. And no woman wants to hurt their unborn child, so this remains a complex and sensitive area and a factor in substance use. We have women who stop using street drugs instead of relying on alcohol instead, and not understanding that alcohol, due to its interaction with the bloodstream, can impact cell development, and this is the most damaging drug of them all. The second is tobacco. So now let's look at a woman with FASD who might be exhibiting a brain injury that impacts their own ability to manage successfully and efficiently. This individual may lack the educational supports that they would require to manage their disability, and in fact then may consume alcohol because of their own disability and produce children with alcohol, and FASD can impact that individual's ability to get the supports they need to successfully navigate their own pregnancy, and then overall, which is even more concerning, individuals with FASD have a higher mortality rate, 45 times greater the risk of dying by the time she's 50 years old than a woman who may not have a child with FASD. So that's really significant. Understanding fetal development gives a platform for understanding this disability. In the early 1960s, the drug thalidomide, prescribed to pregnant women across North America and Europe, used to ease the symptoms of morning sickness, which was a common complaint during the first trimester of pregnancy, and many of the children who were exposed to this particular drug were born with malformed limbs, and it was subsequently proven that the drug interfered with fetal development during the weeks that the limbs were forming. It was this discovery that led the medical community to begin considering the implications of substances on the recognition of a pattern of fetal damage during gestation. And so, in the first trimester is the profound sensitive time. If you look at this chart here, that shows that unlike limbs, the brain develops continually during pregnancy, so it's vulnerable to alcohol's damage for the full 40 weeks of gestation. So if you just pause the video here and take a look at the slide, you can see here where different developmental components take place and the kind of damage that it can take place during these periods. Fetal alcohol syndrome is perhaps the best known alcohol-related birth disorder. It was first reported scientifically in 1968 by Dr. Paul Lemoyne of France, and in 1973 in Seattle, Washington by Doctors David Smith and Kenneth Jones. Both medical teams observed similar traits in newborn babies of women who were alcoholics. The children were of low birth weight, small in their gestational age, and had small heads. Among the unusual features they had were wide-set eyes, as you can see depicted here, thin upper lips, and a poorly defined philtrum, the divot between the nose and the upper lip right here. The abnormalities in the heart, organ, and bone, often in the hands, were noted, and seizure disorders, poor muscle tone, and listlessness were also observed. The infants slept and ate poorly, appeared to startle easily, and were difficult to arouse and were difficult to soothe or settle. These infants failed to thrive, and this was a common reference at a time when children were not developmentally or not developing normally. And we didn't know the cause for this, and the researchers followed these children to understand the long-term impacts of alcohol on their lives. So this is the early work that took place. Over the course of a few years, additional more subtle differences were noted in prenatally exposed children, youth, and adults, and consensus defined multiple diagnosis under the umbrella of what's called fetal alcohol spectrum disorder. And in Canada, the clinical guidelines circulated in 2013 2005, defining clinically relevant, measurable, and quantifiable criteria associated with fetal alcohol exposure. And this work drives Canadian guidelines, drive diagnosis across the globe, and so does the work from Washington. Fetal alcohol spectrum disorders can occur in a fetus developing when a pregnant woman drinks. It affects, as you can see here, growth, face, brain, and alcohol use, and you can now sort of get a sense of how the disorder is classified. Fetal alcohol syndrome is confirmed prenatal exposure to alcohol. That's what it is. There are significant impairments in brain functioning in 3 domains in terms of growth deficiencies, small head, and facial dysmorphology. This dysmorphology includes the small eyes, flattened philtrum, the thin upper lip, and alcohol-related diagnosis if prenatal alcohol history has been confirmed. And partial fetal alcohol syndrome is confirmed prenatal exposure to alcohol, significant impairments in brain function in 3 domains, but not all physical signs of growth deficiency, small head, and or facial dysmorphology. And alcohol-related neurodevelopmental disorder is the confirmed prenatal exposure to alcohol and significant impairments in brain function in 3 domains, but it also the most commonly identifiable disability in the spectrum, and the majority of individuals with this disability will only demonstrate the damage through the disordered behavior, learning difficulties, and other brain-based challenges. Of every 100 individuals with an FASD, only 3 to 8% will present with any physical features, the facial dysmorphology and or growth deficiencies. Secondary disabilities is significant to look at. Researchers found that individuals with visible variances had better outcomes than individuals with fewer or no observed or abnormalities. It's the only disability where the less notable the effect, the poorer the outcomes. Individuals with previous obvious signs of prenatal exposure are seen as disability and receiving parenting support, education support, management interventions, and lifelong support that they need to live successfully in the world with their developmental disability. But individuals with physical signs of the disability without those signs fall within the cracks, and their poor behavior and learning environments mimic behavior disorders. They receive treatment and interventions that are not helpful sometimes and can be damaging, and inappropriate expectations based on misunderstandings and misdiagnosis result in disrupted home and school experiences. And these often escalate involvement with the law, and the criminal justice system has no more success than we see a spiraling effect of conflicts and increased incarceration and vulnerabilities. So the point I'm making here is if somebody is visibly disabled and impaired, they will get better supports, and individuals who may have impairment that's not visually present would be under supported and certainly end up in behavior and or criminal justice systems. FASD is about the brain. If we could see FASD as something like cerebral palsy or Down syndrome, we would likely do better with it. But we know that the individual that is impaired in their brain and is impaired differently, and we rarely see someone with Down syndrome in trouble with the law, and that's because they never commit, not because they don't ever commit an offense, but it's because when they do, we respond differently. So we must understand FASD as brain impairment so that we can really use strategies to curb the systems responding using other strategies that aren't appropriate. Fetal alcohol syndrome is really about a primary brain damage, and each diagnosis under the spectrum includes central nervous system damage. That is brain damage. The brain develops from the beginning of gestation through birth, which means that the person who is vulnerable to alcohol's impact through the entire pregnancy, as you saw from the chart before. Brain research has been fascinating and has explored the impact of alcohol, and there are various parts of the brain involved in a number of disabilities, and these have come in areas, just some of the areas impacted by alcohol. Each individual will have a different spectrum and array of impairments and strength based on their own conditions. In the diagnosis of FASD, 3 areas of brain functionally must be significantly impaired, and to consider the impact of one on the impairment to see if, for example, alcohol has a damaging impact on the brain that might be more profound than somebody having a stroke. Therefore, we are talking about damage that occurs in coping, learning to live, cerebral cortex, the hypothalamus, the corpus callosum, the limbic system, the hippocampus, the basal ganglia, and the prefrontal cortex. Researchers also looking at the alcohol's impact on chemicals and proteins. It's very profound. Alcohol is a poison. Used in high enough amounts, it can cause some significant health issues, and amounts can cause death. It's also a tetragen, which means it causes disruption in the formation of fetal cells, a teratogen. This is because of the rapid and ongoing growth of the brain, the prenatal brain, and the complex nature of the way the cells in the brain develop. The impact can be profound, and the results in the brain could develop in multiple areas. Damage could occur in multiple areas of the brain. So unlike an autism spectrum disorder, where this demonstrates disability in communication and sensory integration, an alcohol-exposed brain, for example, may be damaged in more areas. Let's stop there. Incorrect diagnosis, or there could be concurrent diagnosis happening. So when parts of the brain are considered, FASD can look at like other disorders. So often behavior disorders can be mistaken as oppositional defiant disorder, bipolar, sociopathological behavior, conduct disorders, ADHD, anxiety, depression, attachment, and autism spectrum disorders. And so we often see individual with multiple diagnoses, only to later understand that the genesis of their problem was an organic brain injury caused by prenatal exposure to alcohol. It is for this reason that the diagnosis process is a multidisciplinary one, blending the medical model of psychology, occupational therapy, and speech pathology to make the diagnosis. The diagnostic process includes a physical examination made by a doctor. This should determine whether there was a slow growth or any kind of facial dysmorphology or other physical signs of injury that could cause maybe by prenatal alcohol exposure and physical or brain injury. And it's also vital to exclude other disabilities, including genetic or chromosomal disorders, so lots of exclusion criteria would take place, and the diagnostic process should be multidisciplinary and incorporate input from a number of clinical specialists. The team provides input in many areas where brain damage may have occurred and helps to make interventions recommendations much better. FASD is not a mental health disorder. It's a physical brain damage or a brain injury, although the value and appropriateness of inclusion in the Diagnostic Statistics Manual is certainly currently under review, as we talked about, and there's a video link to the DSM-5's treatment of FASD. Often individuals with FASD are referred to psychologists, in part because their behavior looks like other mental health disorders. So the DSM and the psychologists need to be able to have a placeholder, an understanding of what FASD is or what it isn't, so that the right diagnosis can be made. Certainly a diagnosis could be made without a thorough evaluation of brain functioning, including communication and language processing, sensory integration, visual, auditory, spatial memory, and executive functioning, but each of these elements point to injury and areas of brain strength. It's also important to have a thorough medical examination. Doctors are not only skilled at measuring the physical impairments, but they also can ensure that there's no organ malformations. And their expertise is also a critical role in other diagnosis. And FAD can maybe look like other disorders and other disabilities, so it's vital that these are not ruled out. So the domain's assessed for a primary disability in terms of the brain. It also evaluates through an evaluation that explores 9 areas of brain functions. This information tells us the area extent of which the damage could have occurred and where there are some strengths. So this is part of the diagnostic and strength-based approach to understanding how to support somebody with FSD. This can include impairments like seizure disorders and damages where there might be some more subtle demonstrations of impairment. And so the assessment tells us where the impairments are and helps to decode disruptive behavior, and that might be presented by an individual. And each individual will be affected differently and will have unique areas of impairment and strengths depending on the timing and dosage of their exposure. So the disability always results in significant the disability always results in significant executive and adaptive functioning impairments. And that is a person's ability to successfully plan and organize their life and independently live as an adult. The University of Washington, as I suggested, was the first group to develop a specific criteria for diagnosis. The foundation of the Canadian FASD Diagnostic Guidelines provides a rating scale to help medical practitioners determine the diagnosis, and it also helps in ways of consistent diagnosis across Canada. So Canada is a leader in FASD work. The process of diagnosis is delivered differently across the country in different regions, but the same factors are evaluated: growth deficiency, the face, brain function, exposure to alcohol. Arguably the most critical to a successful outcome is brain function. Having a damage in multiple parts of the brain has certainly a profound impact. So to help you understand what this might look like in a person's life, let's do a case study on a person called James, who is a 12-year-old boy, and he's been at Crown Ward and was permanently removed from care of his birth family since infancy, and he lived with foster parents who were experienced child development and child development. But they became concerned about their ability to care for this child because they're not seeing him progress towards adolescence with appropriate skills. So they face daunting daily challenges around hygiene, self-care, academics, socialization, eating, and sleep routines. And they believed another foster home could do another better job. So now James gets to move, and that, of course, causes a trauma for him. And so this individual, James, who likes to be called Jimmy or James, was referred to a psychological assessment and medical examinations by a local FASD team. And based on a full assessment and an FASD diagnosis was confirmed, the assessment identified several brain-based memory functions specific to auditory behaviors. And some issues presenting as confusing array of behaviors, and this explained his need for constant guidance from one task to another in order to make it through his day. He didn't recall the steps of processing and managing his morning routines. To prepare for school. He wasn't able to do different weekend routines. He understood his limitations, understanding his limitations provided his foster parents with a significant insight on his behaviors and his delays, and it also gave them some direction to engage him more specifically on his routines and structure. This young person demonstrated delayed development milestones in his younger years. He walked and talked late. Assessment highlighted that he was hyperactive. He had poor attention span. He had tantrums. It was defiant, and was one of the most prevalent concerns was his defiance. Jimmy or James had difficulty following directions and a poor capacity to adapt to change in new environments. This was a struggle for him, and transitions were challenging. He displayed a startled response. As an infant, he was identified with failure to thrive, and as an adolescent, he continued to display poor habituation with sleeping and with eating problems. This assessment revealed the need to incorporate a positive reinforcement coupled with prompting for his simple routines. Each morning, Jim's foster parents would engage him in a positive reminder to head to the bathroom. Their series of pictures guided him through his morning hygiene routine and allowed him to manage most of the tasks that he had to do independently. And he was reminded to eat, get things in order, and to prepare for the school bus before the time he was earned, free time was earned for him, so a positive reinforcement. After school, the routine was established as well. The school also was made aware of reasons for his struggles, and a program was set up to support him based on his assessment. Jim's was seated beside a child who was well organized, who could keep up with him on tasks, and at the end of each day he followed pictures that directed him to activities and reduced the number of times he forgot his homework, taking notes, and forgot clothing. And this improved his relationship between school and home as communication shifted away from discussing what he had done wrong into what strategies were working, and each provided their expertise and brought a menu of behavior analysis to the discussion. The changed expectations as a result of assessment were more in line with James's capacity for planning and for his future, and this was more appropriate for his success. In addition, his foster parents received training in the disability specific to FASD and were able to build a full milieu of support and strategies to respond to his emerging issues, and they also received respite and regular time where they could take a break from the demands of raising a child with complex needs. Had the family not received the clarity from the assessment and help interpreting results, the placement would have broken down. The boy would have gone to another foster home, branded as a failed relationship, and it's likely that the new placement would have failed again, and that it would have focused their energy on teaching him skills and setting expectations that were unachievable for him. Understanding his needs, understanding his brain-based behavior, understanding how to support him would create a more successful milieu. The cycle of failure is seen for many individuals with FASD. We set expectations that they are unable to meet. We assume it's their fault, and we see the cycle of use in multiple services: welfare, child protection, social justice, and criminal justice and social justice. So what I'd like you to do is I'd like you to look at these test questions and test yourself. And I will give you a second to take a look at the first question. FASD is the most common disability in Canada. Think about that from this slide. Is that true or false? The answer is true. Number 2, individuals born with an FASD are more likely to be raised by someone other than birth mother. True or false? The answer is true. Half of all pregnancy in Canada are unplanned. True or false? The answer is true, so be careful. Number 4, can always tell when somebody has FASD by looking at them. True or false? The answer is false. Some people with FASD have physical abnormalities and some don't. Number 5, binge drinking causes most of the damage to the developing fetus. True or false? The answer is true. Number 6, poor women are more likely to drink during their pregnancy. True or false? The answer is false. You've learned that women who have a higher education and a higher economic status are more likely to drink during pregnancy. Number 7, memory, judgment, sensory, and language processing are some of the challenges that individuals with FASD face. True or false? The answer is true.